My name is Rachel Wald. I'm the Vice Chair of the Scientific Statement. I'm a pediatric and adult congenital cardiologist in Toronto. I'm a professor at the University of Toronto, and I'm also the Research Director of the Toronto ACHG program.
And in addition to Rachel, Dr. Jeremy Moore from the UCLA Medical Center in Los Angeles, California.
What is the recommended approach to managing ventricular tachycardia?
For ventricular tachycardia and repaired tetralogy of Fallot, this has historically been treated by defibrillator placement. If it's in response to a previous episode of ventricular tachycardia, we refer to this as secondary prevention. Essentially, we're reacting to the arrhythmia after it's already occurred. On the other hand, for patients without prior ventricular tachycardia, but that we deem high risk for future events, primary prevention defibrillator placement can be pursued. Defibrillators in Tetralogy of Fallot are highly effective, and they can prevent future sudden cardiac death events. Unfortunately, it's known that defibrillators can also cause inappropriate shocks, they can become infected, and they may need to be extracted with high-risk procedures, all of which can lead to lower quality of life and patient morbidity. So based on some seminal work in the mid-2000s, catheter ablation is an increasingly utilized manner or strategy for eliminating ventricular tachycardia and Tetralogy of Fallot. So for selected patients with Tetralogy of Fallot and monomorphic VT, this may be even considered a curative approach, bypassing the need for defibrillator placement. The main issue as it concerns the electrophysiologist for transcatheter pulmonary valves is the ability or inability to successfully ablate these ventricular tachycardia circuits after the valve's been placed. For the newer self-expanding valves associated with large proximal skirts that can cover significant portions of the right ventricular outflow tract, we are worried about this as the VTs originate at these exact locations. Although we follow the morphology of the right ventricle, the size of the right ventricle, the health of the right ventricle carefully as we plan the timing of these transcatheter valves, the ventricular tachycardia substrates are also developing insidiously in the background, and we don't have really good ways of monitoring or detecting these ventricular tachycardia substrates. So the period before the transcatheter valve goes in is really the ideal time to assess for these VT, ventricular tachycardia substrates by EP study, and also address them by catheter ablation when they're present.